This podcast series presents a simplified and general overview of the soft tissue healing process. Essentially, there are 4 overlapping phases: bleeding, inflammation, proliferation, and remodeling. In order to successfully assess and manage patients with soft tissue injury, sports therapists must understand the physiological theory, recognise the signs and symptoms, and appreciate the full sequence of events which are normal and typically occur with each of the 4 phases of healing. The immediate phase of traumatic injury is characterised by bleeding and hemostasis. At the time of such injury, bleeding from ruptured blood vessels in the affected tissues occurs to varying degrees. The amount of bleeding depends primarily on the severity and extent of the injury, as well as the inherent vascularity of the involved tissue, although there are a number of additional influential factors. The bleeding phase generally lasts for up to a few hours, and as hemostasis, the mechanism for cessation of bleeding, occurs, the injury moves into the inflammation phase. The body's initial response to bleeding is vasoconstriction, which is triggered mainly by the release of noradrenaline from cellular tissues at the site of injury. Smooth muscle vasoconstriction, or vascular spasm, is the body's natural response to limit blood loss, but will only last for a few minutes at most. Vasoconstriction also contributes to a process known as secondary ischemic death, where tissue cells on the periphery of the injury site, initially unaffected by the inciting event, begin to die due to experiencing a reduced blood supply and resulting lack of essential oxygen, known as hypoxia. Digestive enzymes from gathering phagocytes may also spill over from the injury site and contribute further to the death of surrounding cells. The cells affected by secondary death release a number of chemicals which act as mediators, contributing positively to the resulting sequence of events. The platelet plug mechanism creates a temporary patch where platelets, or thrombocytes, alongside fibrin and leukocytes, stimulated by chemical mediators, platelet tissue factor, become sticky and begin to adhere to the endothelial walls of damaged blood vessels, as well as to each other. This is known as platelet aggregation, and it forms a loose plug. The process of platelet adherence is termed pavementing. The complete hemostatic mechanism, or coagulation cascade, is stimulated by chemical mediation. Coagulation results in the formation of a lattice pattern fibrin patch, or mesh, which acts as a cement and binds together with platelets and cell debris, dead cells. A series of enzymatic responses occur involving plasma protein-based clotting factors. In particular, prothrombin reacts with enzyme factor X and is converted to thrombin, which in turn converts fibrinogen to the resultant fibrin strands, and this is a process known as fibrinolysis, and essentially strengthens the platelet plug and completes hemostasis. During hemostasis, a careful equilibrium between coagulation and anticoagulation, or the blood fluidity mediated by such chemicals as heparin released by mast cells, needs to be reached so as to achieve the desired state. Acute inflammation is the vascularized tissue's initial reaction to any irritant or pathogenic agent or traumatic injury. Watson, in 2006, presents a simplified overview of a recognized sequence of chemically mediated cellular and vascular responses to soft tissue damage, which forms the normal, initial, and essential inflammatory phase of healing. Vascular events essentially aim to provide a supply of specialized cellular effectors at the injury site, and the cellular events essentially attempt to clear the affected site of debris. Typically beginning within an hour of injury and peaking in magnitude of activity for 2 to 3 days, before gradually fading over 2 or 3 weeks, the acute inflammatory phase offers a defense against foreign substances, a disposal system for dead or dying tissue cells, a warning sign of damage and injury, with pain, and attempts to immobilize and compartmentalize the affected area and set up a chain of events for the proliferative repair phase. The 5 classic or cardinal signs of inflammation, which are non-specific to the cause of damage, are swelling or tumour, redness or rubor, heat or calor, pain or dolor, and loss of function, functio laesa. The two essentially chemically mediated hemodynamic events occurring as the inflammatory response instigated via histamine and serotonin from mast cells and platelets, prostaglandins, and the plasma proteins complement cascade and Hagemann factor 12 are vasodilation and vasopermeability. Vasodilation, which is relaxation and resultant widening of blood vessel walls, these are the arterioles and previously dormant capillaries, leads to a decrease in vascular resistance and hence an increase in local blood flow or hyperemia. Fluid leakage from the affected vessels into the interstitial spaces occurs as they become more permeable. Diapedesis is the term to describe the outward passage of blood cells along with plasma proteins and chemicals through the vessel walls, and the extravasated fluid is referred to as exudate. The increasing vascular hydrostatic pressure forces fluid and particulate contents from the capillary outwards into the tissues. Gradually, local blood flow slows and a state of hemoconcentration occurs. The exudate becomes more gel-like as it binds with hyaluronic acid released from mast cells, and gradually, due to reducing stimuli, the hemodynamic response fades. The inflammatory exudate's gel-like consistency helps to contain the injury site and reduces the potential for inflammatory reactions occurring in surrounding tissues. The hallmark characteristics of inflammation are typically visibly obvious: swelling or edema, redness or erythema, and surface heat. Pain occurs due to stimulation of nociceptors during the initial trauma and the resulting acute inflammatory response, with increased pressure on nerve cells from swelling or muscular spasm, as well as from chemical irritation from substances such as prostaglandins, histamine and bradykinin. Nociceptors release the chemical neuropeptide substance P, which stimulates further histamine release from mast cells, hence the experience of pain is perpetuated. Leukotaxin is one of the key chemical mediators in the hemodynamic response, which brings marginating leukocytes, including neutrophils or polymorphonuclear leukocytes, PMNs, and macrophages, to essentially combat any bacterial infection and clean up or phagocytize and debride the affected site. Leukotaxin is one of the key mediators for vasopermeability. Other mediators acting locally include serotonin for vasodilation, prostaglandins for vasodilation and vasopermeability, necrosin, which contributes to the phagocytic response. The complement cascade forms a group of plasma proteins influential to many aspects of the inflammatory response, particularly chemotaxis. Chemotaxis involves a process of chemical release from injured tissues. The chemicals pass through from the tissues to the inner walls of local blood vessels and attract and recruit passing neutrophils and other cells. The chemotaxis of neutrophils involves them being stimulated to make contact with the endothelial cells of the inner vascular wall and then pass through the walls to enter the affected tissue. Neutrophils, which are chiefly responsible for early and aggressive phagocytosis, provide approximately 7 hours of activity and do not reproduce. Hence, as they die, they release chemical mediators which attract macrophages to the site. The process of leukocyte gathering at the injury site has been termed both migration and margination. All events occurring within the acute phase occur simultaneously and continuously interact. The acute stage response gradually fades and generally lasts until damaged tissue has been contained. tissue debris removed, and new capillary networks laid down. The macrophages, which are activated later in their inflammatory phase than other phagocytes, work anaerobically and as such release lactic acid as a metabolic byproduct. This then acts as one of the key stimulants for the next stage of healing, proliferation. As the inflammatory phase fades, so begins the proliferation or early repair phase, typically lasting for approximately 3 to 4 weeks. It's characterized by the establishment of a new vascular network, or neovascularization, in order to support the process of repairing damaged tissue. The actual type of repair depends upon the type of tissue which is predominantly damaged. Knight and Draper, in 2008, explained that there are 2 basic types of initial repair process: reconstitution and replacement. Reconstitution may be perfect or imperfect. Perfect reconstitution is where the injured cells are replaced by identical cells, but this can only occur in those tissues which have a normally high rate of turnover and replacement, i.e. tissue cells which have a high regeneration capacity. Such cells are termed labile and are found in such tissues as those forming the epidermis of the skin and the linings of the respiratory, gastrointestinal, genitourinary tracts. Although dependent on severity of damage and individual capacity to heal, the resultant repair from perfect reconstitution is likely to be perfect. Imperfect reconstitution occurs with tissues formed from stabile cells, such as those forming the liver, pancreas and kidneys. Imperfect reconstitution is where damaged cells are replaced by a combination of identical cells and connective tissue, which will be predominantly type 3 collagen at this stage. Imperfect reconstitution may occur in response to skeletal muscle fibre damage due to the presence of satellite cells, as in a micro-regeneration, but regeneration capacity is limited. Replacement is the repair process for permanent cells, cells which have little or no regenerative capacity, such as those forming nerve tissue, cardiac muscle and skeletal muscle. This type of repair replaces original cells with simpler connective tissue cells. The replacement repair process also occurs whenever the soft tissue damage is sufficiently extensive to disrupt the basic cellular framework. Scar tissue, or collagen, is the tissue which is laid down to replace the original tissue, a process referred to as collagenization. The majority of injury sites heal by repair or replacement rather than regeneration or reconstitution. Garrett in 1990 identified that repair with new collagen does not begin until around 5 days following injury. And Norris in 2004 explains that a lag phase exists, which is the period of time from immediate injury to the beginning of collagen synthesis. During the lag phase, pain and edema are present and tensile strength is reduced. Angiogenesis, the formation of a new vascular network, is an essential factor during this phase of healing. Fresh capillary buds, or branches, begin to appear and are formed from the dividing endothelial cells from existing vessels in the injured area. As they develop, the new capillary buds migrate towards one another, eventually forming a series of capillary arches. Once fully formed, the capillary arches provide a fresh and very effective localized vascular supply throughout the damaged tissue. The network of capillary arches is referred to as the capillary arcade, and the neovascularization facilitates delivery of fibroblasts, myofibroblasts, oxygen and nutrients, and also provides a drainage system for removal of metabolites and other tissue debris, all of which is essential for an effective repair. The stimulation for increased fibroblastic activity, or fibroplasia, is via the presence of growth factors at the injury site, which occurs in response to the chemotaxis provided by platelets and macrophages in the final stages of inflammation. As fibroblasts proliferate, granulation tissue and the extracellular matrix begin to form, and provides the foundation of the repair. The tissue is partly fibrous, i.e. collagen, elastin and reticulin, and partly non-fibrous, i.e. fluid and protein, water, mineral salts and glycosaminoglycans or GAGs. The developing structure of the matrix strengthens and supports the tissues and provides a means for diffusion of tissue fluid and nutrients between capillaries and cells. Fibroblasts themselves produce collagen, proteoglycans and elastin, which are all essential components of scar tissue formation and maturation. Fibroblasts lay down type 3 collagen, which forms a far more significant seal over the injury site than that which was provided by the early fibrin patch and exudate gel during the initial stages of injury. Fibronectin, an adhesive glycoprotein, is plentiful and present at the site and improves the adhesion of fibroblasts to the fibrin patch. Hyaluronic acid, a constituent of the inflammatory exudate, assists in facilitating fibroblast and myofibroblast migration due to its fluid drawing properties. The collagen is laid down in a haphazard manner, essentially creating a quite random matrix. Myofibroblasts also proliferate at the margins of the injury. These are orientated towards the centre of the damaged tissue and have a high actin filament content and resultant contractile properties, which means that they are able to pull wound edges together. Type 3 collagen is fundamentally thin and weak and lacks cross links. It's vulnerable to re-injury, but tensile strength will begin to improve after the first week. As the proliferation phase continues, the original fibrin patch is reabsorbed in a process of degranulation. In addition to its neovascularization, the replacement tissue also begins to develop a network of pressure and tension sensitive nerve cells as a process of localized neurogenesis or neo-innervation, which can lead to pain in the area if the area is externally compressed or stretched. The area is also likely to remain visibly swollen and reddened, particularly if it's superficial due to the increased water content, vascularity and significant amount of collagen at the site, which is still immature. As the scar matures, typically by day 12, the type 3 collagen is gradually replaced by type 1. There also begins a process of devascularization involving obliteration of those newly formed capillary networks. The remodeling phase begins as the proliferation phase is fading and can last for up to a year or more. The more capillaries, fibroblasts, myofibroblasts, macrophages and more all diminish and are gradually reduced, and the activity in the region returns to a pre-injury state. During remodeling, the gradual organization of collagen takes place. This is termed collagen transition. Type 3 collagen is replaced by the stronger, more insoluble, more permanent type 1 collagen, with different tissues, muscle, tendon, ligament, fascia, skin, having different functional and structural requirements. Cross-linkages throughout the fibres occur more readily as fluid content in the area is reduced. Wound contraction via myofibroblast activity continues, and it's generally beneficial to the resulting quality of the tissue unless joint or tissue mobility is compromised. As maturation takes place, the collagen fibres model in response to the lines of mechanical stress applied to them, as in the concept of Davis's law of soft tissue and the long established principle of specific adaptation to imposed demands, the SAID principles. Optimal scar tissue formation occurs when a physiological balance is maintained between its ongoing synthesis or production and lysis, breakdown and reabsorption during the remodeling phase. In certain cases, the normal process of soft tissue healing does not take place. Chronic inflammation occurs when the healing does not progress successfully into the proliferation phase. Essentially a breakdown in the normal process of acute inflammation. Chronic inflammation may persist for months or more and can result in an excess of scar tissue formation and associated functional deficits. Various reasons exist for this occurrence, including the presence of foreign bodies at the injury site, bacterial infections, invasion of microorganisms which are able to survive in large phagocytes, antigen-antibody adverse immune reactions, and perhaps most commonly, ongoing mechanical irritation. Whereas acute inflammation has a short onset and a relatively short duration, by definition, chronic inflammation typically has a long onset and a long duration. However, Watson in 2006 explains that there are two forms of chronic inflammation: chronic supervention on an original acute reaction, or chronic inflammation in the absence of an acute reaction, as in ab initio. Although the characteristic features of chronic inflammation differs according to type, there are likely to be low concentrations of normal chemical mediators and neutrophils are replaced with prolonged presence and activity of larger phagocytes at the injury site, which produce harmful cytotoxins. There's continued production of exudate, but this does gradually reduce, albeit later than normal. Concentration of essential growth factors at the site are reduced. Debridement, or phagocytosis, is likely to be incomplete, and a low-grade inflammatory response persists. Gathering fibroblasts produce a granuloma, or massive weak type 3 collagen, which begins to surround the injury site. This is the start of fibrosis, rather than the normal process of fibroplasia. As Watson from 2006 explains, there will be simultaneous tissue destruction, inflammation, and attempted healing, and different tissues will respond differently to the process. Prentice in 2011 states that there's no recognised time frame in which acute inflammation transitions to chronic inflammation. A large number of factors can affect the overall quality of healing, both positively and negatively. During the early phase, the quality of healing response will be directly influenced by the very nature and severity of injury, its initial management, and the degree of post-injury mechanical aggravation, as opposed to appropriately graded therapeutic mechanical stress. Early presentations, such as excessive edema or bleeding, hematoma formation, or a large degree of tissue separation or muscle spasm, can all impede the normal process. Other important factors to consider which have certain influence on healing include the age of the individual, general health and presence of comorbidity, whether operative intervention was undertaken, i.e. repair or reconstruction, infection, immunosuppression, systemic vascular disease, diabetes, nutritional deficiency, and in particular vitamin A and C, minerals zinc and copper, and protein. Medications, especially in the case of soft tissue injury, corticosteroids, non-steroidal anti-inflammatories, and anticoagulants. Hypertrophic or keloid scarring can also lead to less desirable local outcomes. Hypertrophic scarring is characterized by excessive collagen deposited at the injury site, and keloid scarring is characterized by excessive collagen deposited in the surrounding tissue. Placek and Boyce, 2006, explained that glucosamine, found within type 2 collagen, has importance in the process of soft tissue repair, being a precursor for such compounds as chondroitin sulfate and hyaluronic acid. Glucosamine also increases proteoglycan production. However, evidence is limited with regard to its effects when taken as a dietary supplement. Obviously, the sports therapist has a wide range of specialist interventions available so as to support the injured athlete back towards their ideal function, and any management provided should be based on appropriate assessment and will be carefully and individually tailored to suit each particular phase of healing. Beyond this, an important issue surrounding therapeutic care is that of patient adherence or non-adherence to the therapeutic intervention and advice. Furthermore, even if the patient or athlete is adhering to the recommended program, there's still potential for re-injury. The resulting tensile strength of tissue following minor injury is an indicator of outcome. According to Hauglum 2005, when overviewing average healing timeframes and outcomes in different tissues, muscle tissue is likely to have near normal tensile strength after 7 to 11 days, and with a 90% contraction ability following the remodeling phase. Tendon strength is likely to be 85 to 95% normal, and ligaments likely to be near normal within a year. By comparison, articular cartilage is likely to be near normal within 6 months, and bone within 12 weeks following injury. It's important to recognise that although a completely successful outcome is highly likely for an uncomplicated soft tissue injury following sports therapy intervention, it can't be guaranteed. So here endeth the short soft tissue repair process podcast series 2012. Hope it's not too complicated or confusing. Hope it's a little bit helpful. Thank you.